Thank you so much, Dr. Dilanta and the Ministry of Health for inviting me to deliver this talk today. And I'm very much happier that that there are not only doctors, there are other health categories also watching this today. So it is important to deliver this talk in a language which is closer to everybody. So and whenever it is necessary, I might use English language as well. So please bear with me. This may not be a complete English presentation in English. Right. So to start with, so today basically a sharing experience kind of presentation that I'm going to do. So it's only a fact-finding mission. Mystery of dying due to COVID-19 we'll talk about more to provide a closer look at the patients. Seeing and knowing is believing. That's අපි දැක්කොත් විතරයි අපිට මේක විශ්වාස කරන්න පුළුවන්. So මම ඔයගොල්ලන්ට ඉස්සරහට පෙන්නන්න යන දේවල්. So most likely that you may not have seen before. දැකලා නැතුව ඇති. So not to admit any impediments to the greater services that we are doing in Sri Lanka as a team, and appreciate all the hard work done by public as well as the curative sector which related to the Ministry of Health. And thank all the categories of staff who have rendered their services without limitations. I just switched off my video as well because this is right. So one patient to one patient to one patient or a case to us may be a whole world to another. Like say for example, for a child, wife, husband, mother, father, brother, sister, friend, etc. So so one life is important to everybody. Place yourself in a HDU ICU bed down with COVID for a moment. Just as the පියාගෙන හිතන්න ඕගොල්ලෝ කවුරු හරි HDU ICU bed එක COVID වෙලා හිටියොත් what will ඕගොල්ලන්ට මොනවා හිතෙයිද කියලා. So think like that. All the patients are the same. So we have a we have a responsibility of everybody. So today's outline of the talk is mainly little bit lengthier presentation today, just to give you outline. Can't make it කෙටියෙන් කරන්න උත්සාහ කරන්නම්. ඒ කෙටි කරන්න තරම් අමාරු තරම් දේවල් ටිකක් තියෙනවා ඔයගොල්ලන්ට දැක ගන්න. So little bit lengthier. So has the game changed? We'll discuss, define basic biology. Now what we have, so we'll discuss further. Silent hypoxia ගැන මම කතා කරන්න ඉන්නවා. COVID speed කියලා new entity එකක් අපි කතා කරන්න හිතන් ඉන්නවා. Saturation monitoring and how to monitor with identification of lag period. Not that just saturation එක බලලා probe එක ගලවන එක නෙවෙයි. How to do it properly, and hypoxia and multi-organ dysfunction, and how to reduce deaths at home and in wards. If possible, and daily ward rounds and monitoring for the doctors and the nursing staff, and safer transfer of patients, very important. Patient when he come අපේ center එකෙන් තව තැනකට යවලා හම්මෝ යවාගත්තොත් ඇති කියලා හුස්මක් අරිනවට වඩා, is there anything more that we need to know about the transfers and how to transfer the patients safely කියන එක ගැන අපි කතා කරන්න ඕනේ. And the basic oxygen giving techniques and what to do and what not to do. Oxygen එකක් දෙනකොට අපි හැමෝම අපිට පුරුදුයි oxygen දෙන එක doctors ලට nurses ලට අපි හැමදාම කරන දෙයක්. නමුත් ඒ වගේ තියෙන pitfalls මොනවද, කළ යුතු සහ නොකළ යුතු දේවල් මොනවද කියලා ටිකක් කතා කරන්න බලාපොරොත්තු වෙනවා. And how to avoid steroid misuse, කොහොමද steroid වැඩිපුර නොදී ඉන්නේ, and triple therapy and triple measures කියලා ඔයගොල්ලෝ දන්නම දේවල් ටිකක් වචන දෙකකට කැටි කරලා මතක තියාගන්න දේශයට අපි introduce කරන්න යනවා. So next thing, has the game changed? As you all know, the number of cases are increased. 30 to 60 age group. Some do not have any significant risk factors. Right. There are a lot of examples. Young pregnant lady, saturation dropped suddenly to 70% out of the blue. 35 female with PV bleeding and transferred for a blood transfusion, and 44 female with chest pain, diagnosed with STEMI. So there are so many cases to discuss, but I have just picked few cases to give you all a closer look, and whenever, wherever necessary, to do some real-time videos, and these all videos were recorded with the consent of the patient for the education purposes and to training other junior staff. So, and ගොඩක් සමහර videos වගේක් තියෙනවා අපි බලමු. සමහර කෙනෙක්ට මේ videos දකින්න දැකලා නැතුව ඇති. නමුත් මේ videos වගේ ලෙඩු තමයි ඔයගොල්ලන්ගේ wards වල දැක්කමත් ඉන්නේ. So if you look at them closely and systematically, you will see all this today in your wards. So again, අපි අර කතා කරපු එක trends වැඩි Reuters කියන විදිහට. So ඒක අපිට අපේ news වලත් ඒකමයි කියන්නේ. So we will go back to a patient case scenario. So this was a 35-year-old male patient transferred on 17th of April to base hospital Homagama, and has had a PCR test on 14th. And patient has had fever, shortness of breath on exertion, and cough for 4 days prior to 14th. And saturation on arrival was 94% with 6 liters of oxygen, and patient was dyspneic on exertion. So mind you, the patient has admitted to the previous place on 14th and stayed there in a smaller ICC or a hospital for at least 3 to 4 days before being transferred to a higher level care hospital. And by the time patient already has developed dyspnea, and dyspnea at rest with oxygen, patient is oxygen dependent as well by that time. And this was the chest X-ray which was taken on 19th, one day after the HRCT scan was done, because we have a HRCT machine at home, so we were lucky to have sometimes the HRCTs are being done before the chest X-rays when needed. So this chest X-ray can go easily unnoticed in a smaller hospital with the, but if you carefully see, there are changes. Now this is the මේ එක දවසකට කලින් ගත්ත CT scan එක. ඔයගොල්ලෝ ගොඩාක් මෙතන different categories වල staff ඉන්න හින්දා මම කිව්වොත් එimhe මේක සාමාන්‍යයෙන් මේක කළු පාටට තමයි lung fields පේන්න ඕනේ. But these are like all whitish to virtually there is no lung tissue at all. So this is again same thing. So again, summary, patient same thing. ICU patient was oxygen dependent on 18th, sent to ICU, CPAP, high flow, intubated, ventilated. After 3-4 days, patients come to death. Avasana. Right. So the next thing what I want to tell you all is that saturation less than 94. Kela, if somebody tells you, what do you mean by that? What do you mean by saturation less than 94? Is it a normal figure according to our national guidelines? That is the cutoff point to start steroids and escalation of treatment. So we need to know the difference between saturation at rest versus saturation after exertion. They are not the same. So rest, the saturation may be higher, and after exertion, it can drastically drop to life-threatening levels. So that is one thing, one take-home message, if at all, if you want to take from this lecture, to check the saturation at rest as well as while on exertion or while the patient is on ambulatory state. So again, something to do with all of us are familiar with these pulse oximeters, monitors. There are values, trends, signal strengths, and the waveforms, the sounds, everything is important. So this is a beautiful piece of equipment. So all you need is this to diagnose COVID these days, if at all. Yes, yes, of course, with PCR testing and all. The next thing is, whenever somebody tells you, or whenever a nurse in charge says saturation 96 in the nursing nursing documents or the doctor's documents. We need to know whether the saturation is whether the saturation is 96 or on air, or whether this patient is like a resting patient, can it the saturation like a with oxygen, the without oxygen කියන එක අපිට දැනගන්න ඉතාමත් අවශ්‍යයි. ඒ නිසා please make sure that whenever you are documenting saturation values and to write the amount of oxygen and whether first thing whether the patient is on oxygen or not and how much of oxygen and in what equipment, whether it's on nasal prawns or face mask or NRBM. So it's very important, and it is needed to emphasize the value of resting SpO2 versus post-accessional SpO2, SpO2 with oxygen versus SpO2 without oxygen. Those two values are not the same. Sometimes it can get misinterpreted if not documented properly. So sometimes patient can get discharged with these values, and unfortunately patient may be on oxygen by that time. Things have happened. So next thing is the life is possible with the saturation below 70%. Saturation less than 70 na ජීවත් වෙන්න පුළුවන් මිනිසුන්ට. Yes. Short answer is yes. Now if you think of the Everest climbers, Mount Everest climbers, due to acclimatization, sometimes their saturation drops to below 60s, 70s, 40s even. Recorded things are there, but that happens over weeks to months. They are acclimatizing to that situation. But what if this saturation drops within minutes to less than 70s, 60s on a normal patient? So can the life can they survive with that sort of can they adapt to this sort of low saturations? So this is again the beautiful article which I always refer to. This was published in Critical Care Perspective last year, written by Martin J. Tobin, and he's writing COVID silent hypoxia is baffling to physicians. So baffling is really baffling, and you don't know head to tail of sometimes what is happening initially with these patients. So this is not the same that we have already seen. So they what they say is that patients with coronavirus disease are described as exhibiting oxygen levels incompatible with life without dyspnea. The pairing of happy hypoxemia, but more precisely termed silent hypoxemia, is especially bewildering to physicians and is considered as defying basic biology. So this is something which we haven't seen yet, seen so far with our teachings. So that's what they say according to this article. And it's again, I'm just reading out these highlighted parts. Without knowledge of these mechanisms, physicians caring for patients with hypoxemia free of dyspnea are operating in the dark and placing vulnerable patients with COVID-19 at considerable risk. So this is what this article says. That is not my opinion, that is their opinion, and I'm day by day it is proven upon the cases that we are seeing, and we are seeing the number of deaths these days. Not only in Sri Lanka, it's everywhere. So okay, now shall we see a video now? Now this is a 83-year-old or 73 rather patient, and we should just see whether we can pick anything from this. So this is a 73, 83-year-old patient, and this patient was completely asymptomatic. So when he first came, a saturation of around 77, and patient looks perfectly normal. No dyspnea, no increased work of breathing at all. But just observe the pulse oximeter, saturation was 82. So මේ වගේ කෙනෙක් අපි දැක්කොත් එහෙම සාමාන්‍යයෙන් අපි so it's sorry for using both languages today. I was requested to do like this. So since there are a lot of other category staffs and for the sake of everybody, so this is something which we need to know carefully. Now this now if you when you see a patient like this with a saturation of 82, අපි මොකද කරන්නේ? මේක වෙන්න නම් බෑ, patient dyspneic නෑ, එක්ක saturation probe එක වැරදි, එහෙම නැත්නම් ලෙඩාගේ ගෙනිය පුතේ තින්ත ගාලා ඇති, එහෙම නැත්නම් මෙයාට COPD වගේ මොනවා හරි ඇති, එහෙම හිතලා ගාලා we tend to disregard this because we were taught like අපිට කිව්වේ ලෙඩා දිහා බලන්න machine එක disregard කරන්න කියලා. We were taught like that. So because clinical first කියන අපිට එක තමයි තිබුණේ. නමුත් දැන් මේ patient ගත්තොත් quite correctly she had a saturation of 82. Now if you see the first somebody detected low saturation correctly, you have oxygen wala damma. Later somebody thought, okay, this patient is normal, you know, need oxygen, and put the patient back, take off the oxygen, and the next day or few hours later it has dropped to 67, and still patient is mildly symptomatic, and this is the time may escalate karanda siddha une treatment. So these things can happen if you do not know and if you do not believe that, you know, usually api dakapu patients with heart failure and COPD and all, so when their saturation drops below 90, they show some increased signs of work of breathing. But these patients, certain group of patients, not all patients, certain group of patients, they do not show clinical signs of overt hypoxia initially. This is the group we are talking about, the silent hypoxia. This is a subset of people. This is the arterial blood gas at that time. This is not a venous blood gas, mind you. All the values are compatible with ABG. And this was a chest X-ray. Yes, you can appreciate some signs. So this patient had a longer stay, 17 days in ICU, beautiful management at ICU BH Homogama with all the escalation of treatments. But luckily, she didn't need any intubation. So after 44 days of hospital stay, she recovered, went home, and she came back 2 weeks later to thank us all. Right, so when you see the look of her face, she's happy. Now the stress saturation is like 97, and patient is happy, and it doesn't drop below 97. So just imagine a initial diagnosis of a patient. Again, the same patient. Patient looked the same, no dyspnea, nothing. Saturation was 77 or 80. But now the patient looks little colorful, but still patient saturation 97. This is after nearly 2 months of time. So it takes like longer to recover, and now she's up and well. So this is one good example of silent hypoxia managed properly. Right. So pathophysiology, there are a lot of things, a lot of pathophysiological theories are there, but basically in the lungs there's lack of oxygenation. In the blood vessels there's hypercoagulable states and microangiopathic, and a lot of areas there are clots forming, and there's cytokine storm with the inflammation, and also interplay of these three things will give us to various outcomes. Again, hypoxia driven multi-organ dysfunction, very well established entity, because no tissue can live without oxygen. So that is the fundamental, right? Hypoxia, inflammation with cytokine storm, thrombosis, and there's an interplay between this thing. Hypoxia can worsen inflammation, and it can worsen thrombosis, and you know. So once this never-ending cycle starts, so we have to break the cycle from somewhere. Otherwise, the patient will day by day they will go into severe ARDS and respiratory failure. Again, the same thing. So hypoxia there's a very big relationship between hypoxia and exertion. Your saturation is the oxygen content of the blood, oxygen, how much of hemoglobin is saturated, and that depends, and the using up of the balance between the oxygenation and the usage of oxygen, and that one of the main factors which basically contributes is the exertion, where you use up your oxygen, and also the comorbidities place. So interplay of these three things with the previous higher cytokine storms and inflammation, thrombosis, and all those factors. The final thing is multi-organ failure leading to ARDS, and irreversible ARDS leading to uh, irreversible state. So if you do not uh, sorry for the spelling mistake. So if you do not make the patient hypoxic, there is a high chance that the patient might survive. So that is the take-home message we can take from this one, because hypoxia and exertion and comorbidities you can just adjust, but cytokine storm, thrombosis theories, yes, you may able to, but exertion or oxygen using methods, oxygen වැය කරන methods අපි අඩු කරගන්න පුළුවන් නම් මේ deterioration limb එකේ bad වෙන period එකේ hypoxic period එකේ, so there is a high chance that the patient can survive. So we will look for the evidence, and I will show you some good videos of that. So minimal exertion during this initial phase is life-saving. So this is proven again and again and again. So whenever there is a bystander, whenever there is support inside the ward, their survival increases. So that's right. So again, coming back to the management of COVID pneumonia. So all of us, whether you are a nurse, whether you are a doctor, we need a working diagnosis. Working diagnosis at the doctor's desk. We need to know what we are doing exactly with these patients. So to support that working diagnosis, hypoxia is observed in almost all. So all the COVID pneumonia patients who are getting deteriorated are, at some point they will show signs of desaturation. Direct effect of COVID pneumonia and hypoxia is well established. Other than hypoxia, so many other contributing factors plays a role. Mind you, it is a multifactorial. But why we are talking more about hypoxia is that that is the only thing that we can readily do some intervention even at a smaller hospital. Even we can give oxygen, or we can reduce the activity level and we can adapt some oxygen conserving methods. So interventions are really available for that method. So that's why we need to talk more and more on hypoxia part, but of course, other multifactorial things are also there. So like inflammation, cytokine storm, thrombosis, and there's a collateral damage of COVID, and these things may go very, very unnoticed. So this is again a beautiful working diagnosis of classification of hypoxia, hypoxia-based right, sorry. So this is again a hypoxia based classification. They have this was published in Medscape. They categorize the patients into 3 zones: red zone, blue zone, and the subclinical zone. And what they say is, if you catch the patients early, like these all are COVID pneumonia patients. As you know, COVID pneumonia patients can be asymptomatic at all. Sometimes they can show some early exertional desaturation. Sometimes they can show overt desaturation, but without obvious clinical signs, which we call them silent hypoxia. And sometimes, with hypoxia plus overt signs of ARDS. So what they say is, if you wait till the patient develops this ARDS, that means if you wait till the patients develop signs of increased work of breathing, and if you push the patient to irreversible ARDS, there's little you can do. And even at the best centers, their survival rate is more than just hovering around 50. So, and this end, if you catch early, it's a big yield, yes, less resources needed. And if you wait till the patient develops patient goes into red zone. This is a continuum of, you know, එක patients ලා හිටපු ගමන් out of the blue හිටපු ගමන් මෙතන ඉඳලා ඉවර වෙලා එකපාරට උදේ නැගිටිනකොට patients ලා මේ ARDS මේවා වෙන්නේ නැහැ. So there has to be, you know, there is a rapid progress. Some patients, yes, quickly they degenerate, yes. So, but you can observe this in the wards why this is happening. So even that's what they say. So what they say is that if we move the whole window of treatment from red zone into the blue zone, there will be a logarithmic collapse of the resources needed to fight this disease. It's quite correctly. And there is no win fighting in the red zone. If you wait till the red zone and if you start acting at this point, there is always, there's no win situation. But act proactively, act quickly, and don't let the patient go into this stage. Again, there's a new observation that we have made. There's a window period, like now the patients who are during this window period, there's time, you know, those are the patients with COVID pneumonia, either they can be asymptomatic, or sometimes, you know, these asymptomatic patients in the subclinical zone may show signs of exertional desaturation. That means ඒගොල්ලෝ චුට්ටක් ඇවිදලා ආවට පස්සේ ඒගොල්ලෝගේ saturation එක maybe saturation එක පොඩ්ඩක් අඩු වෙන්න පුළුවන්. ඊට අමතරව the second thing is that, you know, if their saturation drops below 95 or 94, we call them hypoxic, but they may not show overt signs of increased work of breathing. A group එකක් තියෙනවා අර blue zone එකේ හිටපු කට්ටිය. And the third group is like overt hypoxia plus ARDS. So the window period is that, you know, that before developing signs of ARDS, there's a period, right? So ඒ වෙලාවේ මේ ලෙඩු ගෙදර ඉන්න පුළුවන්, ICC එකේ ඉන්න පුළුවන්, ward දෙකේ දවස් දෙක තුනක් ඉන්න පුළුවන්. Sometimes ඒගොල්ලෝ මුලදී complain කරන්නේ උණ කැස්සහක් තියෙන බිස්සාව පොපි මහන්සිය සමහරලාට වැඩ කරනකොට විතරයි. But ටිකෙන් ටික ඒගොල්ලෝ they go into overt signs of hypoxia. And so once they develop respiratory rate එක වැඩි වෙලා dyspneic කියන stage එක ආවට පස්සේ still you can, if you act promptly, but it's very difficult. So timing of PCR plays a role because it doesn't correlate with the disease onset. Degree of exertion is the single most relevant factor which we have to have control over. So, and comorbidities and those, various other factors play, as I said. So it's very important to catch these patients during this window period. That means before they develop signs of overt respiratory embarrassment. That means before they develop signs of increased work of breathing. Again, to sum up everything again, subclinical zone, detection zone, and red zone. So these two zone people, we need to catch them early and start giving interventions before till they now. If you keep the patient at home or in ICC till they develop increased signs of work of breathing, or patients කියනකම් patient මට බුදුම්මෝ මට අමාරුයි කියලා කියනකම් ඉන්න නැතුව, is there a way to detect these patients early? That is what we are focusing more during the next few minutes of this presentation. Again, the same thing, subclinical zone. So there are two groups. Whether we can catch another group where they show no signs of, no overt signs of, so they may be having fever, cough, shortness of breath, on mild exertion, but no desaturation or no signs of increased work of breathing at rest. But ඒගොල්ලන්ට අපි පොඩ්ඩක් toilet එක ගාවට ගිහිල්ලා ආයෙ pulse oximetry ගාවට එන්න කියද්දි saturation එක drop වෙනවා නම් below 94. So they are the group that we need to check. Yes. So මෙන්න group එක අපි we call them COVID speed. That means subclinical pneumonia with evidence of post-exertional desaturation. Be silent. And how to do that is the modified exertional desaturation test protocol. We will see how it's been done in the next few slides. Again, same thing. I'm telling this over and over again that these are the patients with COVID pneumonia that you'll be seeing in these wards. You know, these patients show these signs beautifully throughout their hospital stay. Just that we are not looking and just that we are not picking them up in the right time. Asymptomatic COVID pneumonias are there, COVID sleep patients are there, and COVID pneumonia silent hypoxias are also there, and COVID pneumonia ARDS. So it's also sometimes you know, මේ patients are ගෙදර ඉන්න පුළුවන්, පාරේ බස් එකේ ඉන්න පුළුවන්, or වාට්ටුවට ඇවිල්ලා දවස් දෙක තුනක් ඉන්න පුළුවන්. Right. So again, window period, does it exist? Yes, it does. And I want you all to observe this phenomena. Seeing is believing. The same thing. So during these patients, degree of exertion is uniformly observed as the culprit of pushing them into early desaturation. And if they exert, you know, they just you know, deteriorate. Now ඔයගොල්ලන්ගේ වාට්ටුවේ ඉඳලා නිකන් බලන්න ඇඳින් බහැලා ඉඳලා টয়ලට් එකට යනකොට යන්න කලින් කොහොමද කියලා টয়ලට් එකට ගිහලා ඉද්දි කොහොමද කියලා HDU එක ICU එක එහෙම නැත්නම් ඔක්සිජන් දාන ටික අපි allow කරොත් එයාට ඇඳින් බහැලා ගිහිල්ලා ඉන්න කියලා. Just observe before and after. So even day by day we are seeing it quite often. Unfortunately, අපිට ඒගොල්ලන්ට අර කළ යුතුයි, but dengue වගේ, not like in dengue where we during that critical period we never allow them to get down from the bed, but unfortunately patient has to, they will have to do some of their work by their own because of the gap, the distance between us and the patient. So if you catch these patients during this window period, there is a hope for survival. That is uniformly observed. And whenever where there are the patients who are lucky enough to have a bystander or in the form of test positive relative or somebody, their survival is much superior to the others. And again, the same famous analogy, you know, if you can catch them early, you know, if you can fix this point up there, there's no need of these ambulances and ICUs theoretically, but unfortunately, a lot of people you can catch, but there are certain other things like direct COVID effects of myocardium, direct COVID effects of other organ dysfunctions can suddenly deteriorate with arrhythmias and all. That also does happen, but majority, you know, you can catch them early if you see carefully. Now, I want you all to concentrate on this video. Just see the video and tell me who the patient is. Make a leda kawuda kiyala එක්ක ඔයගොල්ලෝ මට පෙන්නන්න පුළුවන් නම්. There are 3 patients. So this is the HDU of West Hospital Homagama. Right. So who is the patient? Is it the patient who are seated on the bed, or is it the patient අර කිරිබෙද බෙද වාට්ටුවේ ඇවිදලා හිටපු ළමයාද කියන එක? So unfortunately, this is the patient. You know, this is what this whole disease is about initially, right? So this was a saturation chart quite correctly. On admission, 100%, 100%, 98, 98. There's no problem whatsoever. And during this time, we did this modified exertional desaturation test protocol. And before starting, it was 99. And we just asked the patient, we just asked the patient to, once the patient pulse oximeter gawata වාඩි වුණා, 8 සැරයක් ඉඳගෙන වාඩි වෙන්න because minimal bare minimum exertion level, and you observe the pulse oximeter for another 2 minutes post exertion, and it dropped to 95. Is it may patient ge eka concern ekakda? So that is the main thing that we need to make. So we will see. So this was the test that we did. Now for the make a doctors letter, junior doctors letter, nurses letter, just බලන්න අපි මේක pulse oximeter දැම්මා, හොඳ wave form එකක් තියෙනවා. ඊට පස්සේ value එක 99 above 96 තියෙනවා. patient chest pain එකක් මොකුත් මේ එකක් නෑ. ඊට එහෙම අපි ලෙඩාට කියනවා ඔයා ඒ පුටුවේම 8 සැරයක් ඉඳගෙන වාඩි වෙන්න. හරි සරල දෙයක්. and හැබැයි pulse oximeter වෙලෙම අපිට හොඳ value එකක් ආපු ටික ගලවලා අයින් කරන්නේ නෑ. 8 වෙනි සැරේ වාඩි 8 සැරයක් 10 සැරයක් max වාඩි වෙච්ච හැටිය අපි we observe it for further 1 to 2 minutes. Just see what is happening with the value. Just see what is happening with the value. So sometimes during the test, එකක් අඩු වෙන්න පුළුවන්, but it comes back to normal. So that is uniformly observed. Now we have stopped නැවතිලා ඉන්නේ and see the time. Now after 20 good 15 to 20 seconds, the value starts dropping. But mind you, make a pulse oximetry ගැලවිලා හැමදේම patient given on the pulse waveform එකක් තියෙනවා, pulse oximetry එකේ on the signal strength එකක් තියෙනවා, right? So it dropped to 95, and you can see that it is hovering around 95 for a few more seconds before it is being reverted back to 99, the usual normal. This is very physiological phenomena because always your desaturation lacks the oxygen expenditure. So, and slowly it will come back to 98. So this is what we have. So this is how the test is being done, and this is how we look at. So this is very significant, 3% drop from the baseline. So it was, to start it was 99 and it dropped to 95, actually more than 3%. And just see, so is it a concern in COVID patients? So this is the earliest that you can catch COVID patients, if at all, right? So now say for example, with the saturation of if you mail it out, usual, but if the patient is a manual worker who's doing usual daily work, so depending on the degree of exertion, your saturation drops further. Yes. And let's see the progression of the patient. So and unfortunately now that patient, the same day we could get a CT scan of the same patient, see how the CT scan COVID changes, early COVID changes were there, bilateral pleural based early changes, and this was the reporting by the radiologist, confirmed the COVID pneumonia. But see the D-dimer levels, it was more than 5,000. So sometimes one might think that even if you don't do this test, and even if you don't catch these patients, they will improve by their own. But there are certain people, they do have other risk factors, and we don't know their D-dimers. Maybe they are having some other underlying inflammatory disease or something, but the D-dimers was more than 5,000. What if we let these patients manage by their own, and see now then we the saturation dropped to around 90, 92 during the stay, but we started triple therapy, triple measures, and she improved. And see the same test after just before discharge. So all patients needs to undergo this desaturation test before being discharged. Now see the same. Yeah. So this is just before the discharge of this patient. So she is doing the same test again, and now this time it doesn't drop below 99, and she's ready to go. So this is a quite different video. So if you can see carefully the value to see what happens after she stops doing it. Now she and now she's waiting, and see the value. It is 99 and still there. It's 99 and it never drops below 99. So there's a closer look. Now it's almost 30 seconds gone after stopping the exercise. Like in the previous video, it never dropped below 99, and in fact it came back to 100 as well. So she's ready to go after 10 to 12 days of initial diagnosis. So this is what we are, just came to 98, but it's picking up quite nicely. share එක නැවතිලා තියෙනවා. Sorry. share එක ගිහිල්ලා නැද්ද ඒක? දැන් හරිද? Can you sorry for that sorry guys, there's a small issue. Oh, sharing the sharing the share කියලා තමයි වැටෙන්නේ. Top share. හරි. දැන් ආයෙ share කරන්නද කියන්නේ? Sorry. Yeah. So we දැන් හරිද ඩිලන්ත is that
ඔව් ඒක හරි. හැබැයි අපිට මුල ටිකත් අපට ඇහුන්නේ නැහැ. ඒක ටිකක් ඉස්සරහට ගිහිල්ලා ආව නම් හරි. මේ කවුරුවත් දැකලා
මේ හරිය ඉඳන්
ඔව් ඔතන ඉඳලා තව ටිකක් ඉස්සරහට යන්න.
මේක දැක්කද?
ඔව් ඔතන ඉඳලා තමයි නේ ඔය වීඩියෝ එක තමයි ස්ටක් වුනේ.
All right, it's the first video. Sorry for that. Oh, දැන් බලන්න මේක හරිද කියලා. දැන් මේක පේනවද ඩිලන්ත? Yeah.
ඔව් දැන් මේක හරි.
right, මෙතන ඉඳන් පටන් ගමුද අපි?
ඔව්.
right, මේක දැක්කනේ මේක okay නේ?
ඔව්.
All right, sorry. Right, okay. Now so this is now මේ වීඩියෝ එක මට ඔයගලන්ට පෙන්නන්න ඕන. So we'll proceed with the presentation ඩිලන්ත. Okay? Yeah. Right. So this is a patient. Just tell me who the patient is. Now this is a patient. This is in our hospital home patients. India, in our one of the HPUs. So කවුද මෙතන ඉන්න ලෙඩා වාඩිලා ඉන්න කට්ටියද කිරි බෙද ඇවිදින ළමයාද කියලා තමයි අපි බලන්න ඕනේ. So the patient was the one who's distributing the morning tea. And that patient's saturation chart, the nurses monitoring chart, beautifully done, 100%, and it was 98 on the second day. And at that point, we did the desaturation test. We will discuss how it is being done properly, and it dropped to 95. And after that, so this is how the test was being done. So අපි ලෙඩාට වාඩි වෙන්න කියලා saturation probe එක දාලා 8 සැරයක් ඉඳගෙන වාඩි වෙන්න කියනවා saturation එක more than 96 තියෙනවා නම් and patient chest pain නැත්නම් dyspnea එකක් නැත්නම් you just ask the patient to sit and stand and sit for 8 to 10 times and see how the patient's monitor says saturation 98 with a good waveform. The waveform is always very important, and the signal strength just beside the 98 value there's a column, right? So we ask the patient to sit and stand and sit for 8 to 10 times and then observe the saturation. Make important එක තමයි මේක කරලි වෙලා saturation probe එකක් ගාලා ගලවලා අයින් කරන්න බෑ. You have to keep the probe on and observe it for at least 1 to 2 minutes. Always the saturation starts dropping after initial lag period of 20 to 30 seconds. Now see, patient's saturation has started dropping after 20 seconds and it further drops, and it dropped to around 95. 95 දක්වා වැඩි වුණා. Now it is hovering around 95 for some time. And it will, so මේක තමයි අපි අර කතා කරපු initial reversible stage of COVID pneumonia, COVID speed කියලා, COVID subclinical pneumonia with early exertional desaturation. So this is kind of a provoke test which gives us some hope of diagnosing the patients quite early before developing this work of breathing. So now see, it has dropped to 95 and slowly it's coming back to 97. Then it's coming back to 98 as well. So මේ වගේ ලෙඩු අපිට ප්‍රශ්නයක් මේ වගේ ලෙඩු ඉතින් ඔක කොහොමත් හොඳ වෙයි නේ ඉතින් ඔක ඔයගොල්ලෝ කොහොම ඩයග්නෝස් කරගන්න ඕනේ නැහැ කියලා කෙනෙක්ට හිතෙන්න පුළුවන් නේ. Yeah, I think so she will like that කියලා. So let's see the progression of hers. So during the say her saturation dropped a little more further and see so we'll go so during that time, once we detected the desaturation, we did the HRCT and there was early signs of COVID pneumonia, and you can appreciate that. And this is the reporting of the patient CT, and see the D-dimer levels. It was more than 5,000 during this of this patient. So doesn't she go on treatment? So the mildest form of accession that you can think of. But what if මේ patient ඉන්නේ කන්දකුඩ ගෙදරන කනම් තට්ටු දෙකේ ගෙදරක නම් ගෙදර manual worker කෙනෙක් නම් ඔය ගෙදර දවස් 10ක් හරි එහෙම නැත්නම් ICC clinic එකේ වෙන මොනවා හරි ලොකු වැඩක් කරන්න ගියොත් පරිකල නගින්න ගියොත් exercise කරන්න ගියොත් what will happen? Yeah, this saturation will drop further. We'll discuss later. So D-dimer was more than 5,000, and we treated with triple therapy and triple measures, and this is on discharge. All our patients need to undergo the same test on discharge, desaturation test, see if the saturation drops. සමහර වෙලාවට අපේ misnomer එකක් තියෙනවා, මේ mask එකක් දාගෙන ඉතිහාම saturation 3-4ක් අඩු වෙන්න පුළුවන්. normally මිනිසුන්ගේ saturation එක 95-96ට වඩා අඩු වෙන්න පුළුවන් කියලා අපේ පොඩි misnomers තියෙනවා. ඒ හින්දා තමයි අපි saturation අඩු වෙන එකක් normal patient කෙනෙක්ගේ දැක්කොත් mask එක පාත් කරලා හුස්ම අරගෙන ආයෙ saturation එක බලනවා, ඇඟිල්ල මාරු කරනවා. Those things can contribute, but not to this extent. No, see the same test, same machine, same patient, same dress, doing the test after 10 to 12 days of treatment. See if the saturation drops below 99, probably maybe 98 max, but coming back to 99. So this is the kind of reversibility that we are seeing. So this is 10 days, 10 to 12 days apart, initial desaturation. So this is the kind of type of patients that we need to catch early and treat them. Now this is maybe good ආකාරය නෑ මේ ශරීර කුසියක් ඉස්සත් මේ වගේ දෙලෙට 15ක් 20ක් විතර ඒකෙන් 4-5ක් තමයි බෑඩ් වෙන්නේ. ඒකෙන් 100ක් දෙකක් විතර තමයි ICU ගිහිල්ලා අමාරු වෙන්නේ. So if you catch these 20% like 15 to ensure good waveform and document baseline SpO2 and SEP2. If no contraindications, stand and sit 8 to 10 times and observe the pulse oximeter continuously 1 to 2 minutes to detect SpO2 drop after initial lag period of 20 to 30 seconds. So usually always observe this lag period. Pulse oximeter in a value that may not be correct. It takes 20 to 30 seconds. The may test එකම තව විදිහට අපිට කරන්න පුළුවන්. සාමාන්‍යයෙන් අපි ICC වල wards වල එක pulse oximeter එකක් තියෙනවා. Patient has to ලෙඩාට ඇවිදගෙන pulse oximeter ගාවට එන්න ඕනේ. So if you know the baseline value, if you time it correctly, ලෙඩා ආපු හැටිය pulse oximeter දාලි වල විනාඩියක් දෙකක් බලාගෙන හිටියොත් you will see it. But එනකොට එයා ඇවිදගෙන cubicle එකේ ඉඳන් ඇඳ ගාව ඉඳන් මෙතනට ඇවිදගෙන එනකොට ඒ ටික ඇති මේක desaturate වෙනවා desaturate වෙන්න. That minimum exit. But මේ patients ලා වාට්ටුවේ නිකන් හිටියත් 4 සැරයක් toilet එකට යනවා, කෑම ගන්න එනවා, pulse oximeter ඉන්නතන්ට එනවා. So they do a lot of the activities inside the ward, and sometimes in some places අපි ව්‍යායාම program එකක් කරනවා. So see what happens if you ask them to do 10 dips or anything, something like that. Right. So this is again now make a hemo patient කෙනෙම what if මේ desaturation test එක අනිත් කට්ටියට මොකද වෙන්නේ? So මේක මේ again අවුරුදු 75ක් 80ක් විතර 70ක් විතර lady කෙනෙක් අපි යාටත් කියනවා බලන්න මේ mask එකක් දාගෙන. So unless you have a lung condition, lung pathology, COPD, asthma or some sort of a lung interstitial lung disease, something, your saturation should be dropped below 96. ඉතින් තමයි අපි කලින් අපේ guideline එකේ තියෙන 96 වලට drop වෙනකොට so we have to make some arrangements for this patient for close observation. So is again normal med test protocol again වයසක patient කෙනෙක් ඉඳගෙන වාඩි වෙනවා so මේ patient desaturation එකේම drop වෙන්නේ නැහැ අපසරයක් ඉඳගෙන වාඩි වුණා කියලා mask එක දාගෙන හිටියා කියලා even sometimes the main thing is so unfortunately patient pulse oximeter පොඩ්ඩක් ගලව ගත්තා but so quickly ආපහු දාගත්තා sorry for this recordings so we did it in our phones වලින් record කරපුවා of course patient ලගේ consent එක මත so මේ patient ගේ අපි saturation එක බලාගෙන හිටියට අටසරයක් වාඩි වුණා කියලා ඒගොල්ලන්ගේ අඩු වෙන්නේ නැහැ වයසක patients ලගේ so that is for sure you can try this in your hospitals ඒගොල්ලන්ගේ wards වල patients අට කරලා බලන්න පුළුවන් but if anybody is saturation drops to 95 94 it's a cause of concern right so ඒ කට්ටිය වෙන් කරගෙන ඒ කට්ටිය close to monitor කරනවා නම් so මේක පළවෙනි දවසේ වෙන්නත් පුළුවන් දෙවෙනි දවසේ වෙන්නත් පුළුවන් during the stay even after දවස් 10ක් 12ක් ගිහිල්ලා පස්සේ උනත් desaturate වෙන්න පුළුවන් so right so it never drops below 98 so this is a normal response this is again the same test being done by a medical officer from our hospital right so this is a young patient who's doing the test same thing so I'm just showing you all this over and over again is that we need to master this technique if you want to just that are ලෙඩාගේ pulse oximeter දැම්ම ගැලුවා everything නම් මේ වැඩි කරන්න අමාරුයි so her baseline saturation is 99 and we are asking her to sit and stand and sit for 8 times and we observe the pulse oximeter for the further 1 to 2 minutes so we are asking her to stand and sit 1 2 3 4 5 6 7 8 and you observe for further 1 to 2 minutes and if it is dropping starts dropping after it is uniformly observe that it never starts during or soon after if at all if the saturation is already low you can get a very low value but usually if it is dropping it starts dropping after 1 to 20 to 30 seconds and it can happen up to 60 to 90 seconds so it never drops right so again this is another patient now this desaturation can occur at any stage of the disease early phase middle phase and later phase so this patient came with this early desaturation is with silent hypoxia actually the saturation dropped to around 80s and now she is in the recovery phase but still you can observe now so once the saturation is above 96 only we started this test on her just to see what is happening as a discharge criteria so this see what happens her baseline saturation is 98 and we're asking her to do the same stand and sit for 8 to 10 times 1 2 mind you this is after maybe after 2 to 3 weeks of hospital stay 3 4 5 6 7 8 yeah 7 times we ask her to do that just see what is happening with the saturation there's a good waveform so it takes at least 20 to 30 seconds to start dropping so I want you all to observe this lag period very carefully. Now it starts dropping, not immediately after. So why am I stressing this point is that, soon after, if you put the set probe and take it off, you will not observe this. See if that it was start with it was 99, now it has dropped to 96, 95, 94, 93, 92, and again in the reverse order it will come back to usually around 96, 97 value. So this is the kind of desaturation we observe uniformly in the desaturation phase. So what if these patients were allowed to climb stairs and do their usual activities? Now, mind you, this patient is probably after 3 weeks into her illness. So it is very important to demonstrate negative desaturation test at least on discharge. That's why these patients, they go home, they start their normal functioning. Say this patient has to climb so they will desaturate, obviously, and we will see, then you will see all sorts of post-COVID syndrome complications. Now see, this is the state of this patient. So this is kind of desaturation we are talking about, right? So observing the pulse oximeter to identify initial lag period is the key. And so if you do the pulse oximeter check in the conventional way, you will miss vital information. Need to understand the physiology behind that. It is very physiological if you think if the saturation drop always lacks certain period, needs operator commitment to do that. So this test is not done if resting saturation below 96, patient has chest pain, obvious shortness of breath, physical ailments or other patient compliance and observer competency. If these are not there, you will not do it. Right, detect desaturation group early and treat early. So this is the motto. Saturation less than 94 and ambulatory or at rest, you will start escalating the treatment. Idea is to diagnose the group of patients who desaturate below 94, either at rest or after mild exertion. They will desaturate more on moderate to severe exertion if they are allowed to walk and do activities of daily living. අර වගේ පුංචි එක්සර්ෂන් එකකදී saturation 90කට අඩු වෙනවා. So මට ඔයගොල්ලන්ට පෙන්නන්න පුළුවන් සමහර වීඩියෝ සමහර ඒවා තියෙනවා patients එකකදී saturation drops to around 80-70 with mildest form of exertion. So yeah, resting saturation is 92-93 තියෙනවා. pulse oximeter එක ආවට එන්න කියලා saturation එක බලාගෙන හිටියොත් it drops to around 70-60 some patients ළඟ. But they don't show signs of increased work of breathing. But at some point heart එකට lungs වලට එක දරන්න බැරි වුණාම ඒ inflammatory process එක hypoxia driven multi-organ dysfunction එක setting වුණොත් they will show signs of increased work of breathing, and this is we are observing uniformly day by day. So these patients, if you catch below 94 according to the guideline, you can start triple therapy, and we'll talk about triple measures and triple therapy later. So yeah, now this is the time. Triple measures can make a very physiological අපි දන්නම දේවල් නමක් දාලා තියෙනවා for everybody to remember easily. Strict bed rest and minimal exertion depending on the severity of the silent hypoxia, or conserve body oxygen stores. Like in dengue critical phase එකෙත් අපි initial 7 to 10 days යනකම් ලෙඩුම් අපි exert කරන්නේ critical phase එකේදී බස්සන්නේවත් නැහැ. But unfortunately COVID patients, we can't reach them, and the patients are dependent on us, and they have to do all max, not in all centers, but in most of the places, they will have to go and grab the food, they will have to go to the toilet by themselves, by walking, they will have to come to the pulse oximeter twice a daily at least. A lot of things, a lot of activities, a lot of things. Even the patient is on a HDU bed, sometimes, they need to get down and walk up to the toilet. So see what if that happens. So I'll show you this very sad video later. So first thing is strict bed rest and minimal exertions. Second thing is awake cyclical prone positioning with alternate left lateral and right lateral. These are all very proven. So ඔයගොල්ලන්ට බලන්න පුළුවන් saturation අඩු patient කෙනෙක්ට awake නම් යා conscious නම් අනිත් පැත්ත මුලින් අතර නිදා ගන්න කියලා saturation එක after 2 to 3 minutes at least 2 to 3% take away, you know, and supplemental oxygen depending on the degree of hypoxia. So sometimes, you know, these are earlier, intermittent oxygen. So sometimes, you know, we use cylinders on wheels. Some are we ask them to oxygenate before going into the toilet, and soon after coming back to the bed to pre-oxygenate, and while on the bed their saturation is about 94, so they don't need oxygen. So intermittent oxygen for that group, and uniformly desaturate in a catheter less than 94 in a catheter. Now, if they were allowed to walk inside the ward, it shouldn't have happened. But if it is happening, at least wheelchair car, cylinder on wheels, oxygen neck all the times to go to the toilet and all. So this is the place. This is the place where we can intervene most without ඔයගොල්ලන්ට තේරෙනවා ටොයිලට් එකට යනකොට ඔබ්සර්ව් කරන්න ගිහලා යනකොට බලන්න මොනේ තියෙන ඩිස්නියා ගතිය. So අදත් අපිට patient කෙනෙක් හිටියා ලෙඩා ගියා නාන්න. After 10-12 days patient looks okay, she wanted to have a bath, went to the toilet and came back, saturation of 88-89, and patient was breathless after coming back. So these things are there, but you need to avoid them at all times. So the more you know, the more you will practice these things. So triple therapy, again, triple measures, like, you know, everybody can practice this. Almost everybody, all patients, even at home-based patients, you know, quick bed rest and supplemental, bed and prone positioning during sleep, right? And triple measures are like, there are three major pathophysiologies, as I said: inflammation, hypercoagulability, and thrombosis, and dehydration and sepsis. Inflammation, dexamethasone, steroids; hypercoagulability and thrombosis, Inoxa and plus or minus aspirin, depending on the local guidelines. Dehydration, and you should not dehydrate them at all. But maybe patients for some ICC, so their water intake is low, so they are more prone to get dehydrated, and if they dehydrate, they are more prone to thrombosis and inflammation. Nothing happens, you know, with sepsis patients. You know, make it IV fluids more nice, maybe water, maybe ORS, or other forms of ophthalmology, whatever. You need to get some fluids in to keep yourself, unless you are a high heart failure patient or fluid restricted on a fluid restricted diet. So the other misnomer is that, you know, giving furosemide and getting negative balance for patients who do not need this sort of intervention, usually in wards, and most of HU patients, they don't need a negative balance. And saturation drop picture here. Okay, first go to drug my furosemide ටික අපි ඊළඟ බලමු. Disney picture here. අපි දන්න ලොකුම දේ හැමදාම කරන දේ තමයි furosemide ටිකක් අහලා බලමු saturation හරියනවද කියලා. In COVID, unless you have a heart failure or over pulmonary edema, so this happens in maybe late stages of CPAP or in ventilated patients, but in usual other patients, your furosemide and negative balance should not be your first choices. Again, this is easy to remember, as I said, and this effective therapeutic plan with high yield when advocated at an earlier stage of the disease. Triple therapy and triple measures are easy to remember, even for junior doctors, but mainstay is that, you know, you should not prescribe steroids for everybody. So you have to detect the steroid desaturation group. That is what the recovery trial says. And if you give steroids in the initial phases, in the revived phases, there's a high chance that the patient can get adverse effects. So this is only for the patients who are desaturating according to the guidelines. So this med test protocol and detection of speed and silent hypoxia is an easy way to detect this COVID early desaturation group, but others they don't need. And mind you, these patients are like usually around 15 to 20%, but majority, more than 80% patients, they don't need steroids. But unfortunately, that is happening at somewhere in some scale. Yes, and a few more things about medical oxygen treatment at small hospitals. So you will be dealing with, you don't need to, අද මෙතන හඳුනන නර්සස්ලාට ඩොක්ටර්ස්ලාට ඔක්සිජන් දෙන වෙලට ගැන අපි වැඩි උගන්වන්න අවශ්‍ය නැහැ කියලා හිතෙන්න පුළුවන්. but අපි ගොඩක් දන්නවා ඔක්සිජන් සිලින්ඩරයක් දාන්නේ මොකද්ද කොහොමද තියනවද කියලා බලාගන්නේ කනෙක්ට් කරන හැටි ඔක්කොම දන්නවා. but what I'm trying to tell you is that few more important tips. So again, few more things about medical oxygen. Oxygen levels in the body can get very low in COVID pneumonia, can cause tissue hypoxia. Even organ in the body needs organ to survive and to their normal function. So oxygen network කිසිම tissue එකක් survive වෙන්න බෑ විනාඩි කිහිපයක්, especially metabolic rate එක වැඩි tissues වලට ගොඩක් කල් ජීවත් වෙන්නම බෑ. So the hypoxia period එක වැඩි වෙන්න saturation එක අඩු වෙන්න multi organ suppression එක එන්නේ tissues hypoxic state එකට යන ප්‍රමාණය වැඩි. ඒක සමහරවිට even if the patient survives the acute stage, even if they go home, this will manifest as post-COVID syndrome, various renal problems, heart issues, myocardial cardiomyopathies, skin hepatitis, you name it. Anything can happen with hypoxia. So oxygen is very vital, and in the management of. So this is a WHO guide to give medical oxygen in smaller hospitals. So I think everybody is very familiar with these three methods. We are not going to talk about high flow nasal cannula therapy. So nasal cannula, face mask, and face mask with reservoir bag, that is NRBM. These things we are using every day in almost all patients. Escalation of treatment and de-escalation as well. So what are the main points to nasal cannula or nasal prongs? The flow rate is 1 to 5 liters per minute. Make sure that you do not give more than 5 liters per minute with the nasal cannula. Even if the patient saturation is dropping, don't increase the flow meter to 8 to 10 liters with the nasal cannula, because it is very uncomfortable. Too high pressure within the gut, your nasal mucosa get dried up, and you can even, it's very uncomfortable for the patient. So the maximum flow rate is 1 to 5 liters per minute with the nasal. And if the saturation is not maintaining with that, you have to go escalate the treatment for face mask. Face mask අපි හැමදේම දැකලා තියෙනවා nebulize කරනවා වගේ පොඩි plastic cover එකක් එක්ක තියෙන එක. So ඒකේ flow rate එක 6 to 10 liters per minute. So make a very important factor එක තමයි face mask එක දාලා තියෙද්දි you should not give subtherapeutic levels of oxygen. 1 to 2 liters, 2 to 4 liters වගේ පුංචි ප්‍රමාණ දෙන්න බෑ. මොකද මේ mask එක ඇතුළට patient එක exhale කරන, breathe කරන, out කරන carbon dioxide උත් වෙනවා. පුංචි flow rate එකක් දුන්නොත් there's a high chance that the patient will breathe the patient's own exhale there. So that is what you call rebreathing. So rebreathing can happen if you give smaller volumes. So at least to start, if you're putting it as face mask for the nurses and the junior doctors, at least start with more than 5 to 6 liters, and you can go up to 10 to 12 liters max if you want. But if it is not maintaining with that, you can escalate it to NRBM. NRBM can be face mask එක වගේමයි. ඒක පොඩි valve එකක් තියෙනවා. පොඩි bag එකක් එක්ක තියෙන පොඩි device එකක්. මේක දානකොට there are very important factors that few things that you need to know. Make දානකොට again you can't give subtherapeutic levels. මේක නිකන් 2 3 4 5 6 7 8 පුංචි oxygen ප්‍රමාණ දාන්න එපා. Your rebreathing effect is more. So at least you have to start more than 10 liters, 10 to 15 liters වත් දාන්න ඕනේ මේ mask එක දාන්න ඕනේ. එතකොට මේකේ කළ යුතු පළවෙනි වැඩේ තමයි mask එක එකපාරට ලෙඩාගෙන එකට මූණට දාලා ඉවරලා oxygen cylinder එකට connect කරන්න එපා. ඉස්සලා mask එකට connect කරලා 10 to 15 liters ඇරලා make sure that the bag is full before the patient breathes. Bag එක full වුණාට පස්සේ completely full වුණාට පස්සේ ලෙඩාගේ මූණට දාන්න. That make a very important thing. And if the patient is on NRBM, ඔගොල්ලෝ ward round එක බලනකොට මේ bag එක collapse නා flat bag එකක් නා the NRBM effect is not there. Either the flow rate is low or something to do with the wrong valve effect or something. So you have to make sure that the bag is moving if a patient is on NRBM. And again de-escalate කරනකොට NRBM එකකින් උඩ oxygen එක 15 10 කරලා 10 6 කරලා 6 2 කරන්න එපා මේක තියෙද්දි always go back to de-escalate with the face mask and ඒකේ ඉන්නකොට ඒකේ 6 to 10 liters maintain කරනවා තවත් පුළුවන් නම් de-escalate කරනවා නම් මේකෙදි 2 liters විතර face mask එකෙන් දාන්න එපා and third thing final nasal prawns nasal cannula එක තමයි important මේක. Again, very important thing තමයි especially if the patient is on face mask මේ NRBM එකයි මේ දෙක දාගෙන ඉන්නකොට cylinder එක oxygen ඉවර වුණොත් මොකද කරන්නේ? So remember your atmospheric air has 21% of oxygen, but your exhaled air only has 12 to 16% of oxygen. So oxygen ඉවර වුණාට පස්සේ mask එක දාගෙන ඉන්නකොට what will happen? Patient will rebreathe their own exhaled air. So the patient will desaturate quite fast and get easily lethal in that scenario. So advise the patients, advise the doctors, everybody, if the cylinder runs out of oxygen, cylinder oxygen you not mask eliyata galodi warela nikan husma ganna කියන එක. Make to practice until ඊළඟ oxygen cylinder එක connect කරනකම් small hospitals වල සමහරලාට oxygen එක ඉවරයි එදා ඉන්නවා mask එක දාගෙන ටිකක් වෙලා. So you should not allow, at least educate the patient not to do that. So at least they have the luxury of breathing 25% of atmospheric FiO2 during those times. So all of us managing therapy, the COVID patients la manage කරන කට්ටිය මෙන්න මේ වගේ at least some knowledge we need to process within short period of time. Early detection, early intervention, reduce exertion, how to give oxygen, how to escalate, how to de-escalate. කියලා අපි basic knowledge එකක් තියෙනවා නම් අපිට ගොඩක් දේවල් දැනගන්න පුළුවන්, save කරගන්න පුළුවන්, ගොඩක් lives will be able to save. So I'm again stressing this need absolute bed rest like in daily critical period during desaturation phase. So once the patient is in the recovery phase, maybe after 1 to 2 weeks, so you can start mobilizing them. But if you have to mobilize them, always do it with oxygen and oxygen on wheels with a wheelchair or something. Otherwise, the patient will they can have drastic saturation drops and collapses. So there are so many examples that we can go into. But so if the accessional desaturation is there, it will lead to hypoxia, and it will. Say for example, if your heart is in a precarious balance with reduced blood supply segment, if the saturation drops, you can throw up an MI within no time. And on top of that, if the block is more due to thrombosis, the problem get worse. And so this is the other video that I want you all to see now. Now, just observe this patient. This is regarding the transfer of patients. So, just carefully look at this video. I don't know whether the narration is given by the medical officer. This patient, again, 42-year-old lady with COVID pneumonia. And she was on 10 liters of oxygen. The doctor is asking the patient to sit on the bed. That's all. Now say for example, now once the patient seated, saturation drops to 95, even with the NRBA. This is the degree of desaturation we are talking about. These are very unstable patients. මේ oxygen එක දාගෙන වයින්දේ වාඩි වුණා විතරයි 95කට අඩු වුණා. දැන් බලන්න what happens. කිව්වොත් එහෙම ටොයිලට් එකට යන්න හරි විනාඩියකට ගැලවුවොත් මොකද වෙන්නේ කියලා බලන්න. Patient doesn't look this weak at all. ඔයගලන්ට මොන පේනවා? එදාගේ respiratory rate එක. She looks perfectly. Now see how the saturation drops. The waveform එකක් තියෙනවා. See, it drops. And they want to now then make it a silent hypoxia කියන්නේ. So may patient just imagine may patient මෙතනින් පුටුවකට බහැලි කරලා ඇවිදගෙන මෙතන টয়ලට් එකට ගිහිල්ලා නාලා බෙද ටිකක් හොදලා ආයෙ මෙතනට එන්න උනොත් මොනවා වෙයිද? Right? So that is the degree of exertion we are talking about, right?
Saturation
say for
84
example,
වෙලා
it drops to 84, saturation 84 වුණා. And we will අපි මෙයාට දැන් අපි ආයෙ කියනවා
මම දැන් මාස්ක් එක
මාස්ක් එක දාගන්න
ඔක්සිජන් එක දාගන්න ඔයාලට ආයෙ බලාගන්න පුළුවන්
ඔක්සිජන් එක මාස්ක් එක දාගත්තට පස්සේ
ඔක්සිජන් දාපු ගමන්
after a few minutes it starts picking up. So
තව ඉක්මනට නැවත
so but අර ඉස්සෙල්ලා තරම් අර ඉක්මනට දැන් same 10 liters of NRBF නමුත් අර 99 පිච්චර ඉක්මනට එන්නේ නැහැ. It takes some time. So it's hovering around 93. Now see the මේ පොඩ්ඩක් වාඩි වෙච්ච ගමන් මේ වෙච්ච desaturation එක.
දැන් ඔය ඇඟිල්ලේ තියෙන ගලවන්න නැතුවම මාස්ක් එක විතරක් පොඩ්ඩක් පල්ලෙහාට කරගන්න.
Right. Now say for example now if you want to transfer this patient, what will happen? Right, so may patient is මේක එළියට බහැලා බෑග් එකකුත් උස්සගෙන පඩිපෙළකුත් තියෙනවා නම් ඒකත් බහැලා ඇම්බියුලන්ස් එකට නැගලා ඊළඟ හොස්පිටල් එකට ගියොත් මොනවා වෙයිද මේ ලෙඩට? So
මූණේ පල්ලෙහාට කරගන්න. දැන් අපි ඔක්සිජන් අයින් කරා. ඔයාලට පේනවා දැන් ආයි කොහොමද?
So actually so I need to share this for this patient again for various reasons. It was transferred from a smaller hospital to the higher center because of some other pressures. So may patient මෙතනින් මේ 99 තිබිච්ච ලෙඩා පැය භාගයකට පස්සේ අනිත් hospital එකට receiving hospital එකට යනකොට මෙයා හොඳටම dyspneic and patient saturation was around 86 with 15 liters of NRBF. Same patient after half an hour. පැය භාගයකට කලින් patient was very stable on a bed and without dyspnea, but half an hour with ambulance transfer. Mind you, this is with the stretcher, oxygen, continuous oxygen, and patient was not allowed to get down from the bed, stretcher එකට දාලා ඇඳේ දාලා එම අනිත් පැත්තට ගෙනපු එක්කෙනෙක්. So by the time the patient went to the other end, patient was very dyspneic and patient needed high flow nasal oxygen and escalation of treatment, and unfortunately patient after 2 days patient had to patient didn't survive. So this change occurred within 30 minutes. So it's very somebody can say, okay, all right, so this could be a pulmonary embolism. Yes, you can, yes, that could be a possibility, but we observe it every day that patient gets saturation make a galo peti asuවට අඩු වෙනවා oxygen දාපු පෙටි ආය 97ට එනවා. So in a massive pulmonary embolism that reversibility is not there. So we need some urgent measures to reduce COVID deaths, right? So to reduce deaths in homes, advise strict bed rest for all those who are PCR positive, and avoid climbing stairs, running and sports, excessive heavy manual work, and even sex or dancing during this period. I mean the test positive period. Nothing. You are not allowed to do anything, otherwise you will degenerate. Adequate hydration is there, smoking and alcohol avoided, easy and quick access to hospital for those feeling ill, by even with their own transport allowed, it doesn't matter. Manage their acute medical issues without delay. In the wards, in the intermediate care centers, all should rest and avoid climbing stairs, exercise, running and sports, and dancing. With music දාලා නටන්න දෙන ඒවා හැම කරන්න නම් එපා. Adequate fluid intake, all undergo twice a day resting pulse oximetry, checks resting saturation, and do sit to stand med test protocol, and observe it for a longer period, and detect the patients who are COVID speed positive, and start escalating the treatment. Absolute bed rest for all those having silent hypoxia and those having post-accessional desaturation, and especially in the ICU and HDU setup patients who are on oxygen, NRBM, CPAPs, don't allow them to get down and go to the toilet. So use bedpans, especially for HDU and ICU patients. Do not exert them. Use wheelchairs to move inside the ward. X-rays, if an X-ray oxygen at least to give oxygen on wheels. Encourage sleeping prone, left lateral, right lateral positions. Sometimes, they could test positive relatives young healthy කට්ටිය ඉන්නවා නම් වෙන test centers වල sometimes as a measure we tend to get them down as bystanders and transfer to higher levels. It is ඊළඟ එක very important එක තමයි අපි tertiary care level එකේ ඉඳන් දැක්කොත් එහෙම police hospitals වලින් patients ලා transfer වෙලා යනකොට say they come very desaturated and very sad state එකක ඉන්නේ. So minimal exertion while transfer, avoid walking, no carrying bags or climbing stairs. Unfortunately, we know that there's a big gap between the patient and the health care worker due to this infectious nature, but we need to bridge that gap, and we need to get them not to exert too much. Do not take off oxygen while moving to ambulance. Use oxygen on wheels while moving the patients. Very important. Ensure adequate oxygen while traveling in the ambulance. Do not abandon the patients inside the cabin. The data cabin in the Kedivella. So we have seen some patients coming so without oxygen even in the cabin. Cylinder has ran out, oxygen cylinder right? So for that we need to know how we need to calculate the time of the oxygen cylinder according to the flow rate. Anesthetist කෙනෙක්ගෙන් හරි ඒක අපි පොඩ්ඩක් අහගෙන ඉවර වෙලා කොච්චර වෙලා especially if you are transferring a patient more than 2 to 3 hours transport now might need more than 1 to 2 cylinders, and especially somebody needs to be there to change the cylinder. Otherwise if NRBM එකක් එක දාලා වෙලා patient එනවා නම් what will happen? So if there was nobody to change the cylinder inside the cabin, so they can have very deadly rebreathing inside the cabin. So sometimes we see quite even දහනමේ අනුව අපේ ඒ වගේ experiences වලින් මේ සමහර වෙලාවට අපිට කියනවා අපේ ambulance වලින් එහෙම එනකොට සමහර වෙලාවට අපිට unfortunate situations තියෙනවා. අපි දන්නේ නැහැ ඇත්තටම ඉතින් ඒ patient ගේ situation එක එනකොටම bad තිබුණාද wild වුණාද කියලා, but this is more rational to think. So make sure that patient doesn't hypoxic during the transfer and patient doesn't exert themselves too much during the transfer. And to start finally with this is what the doctors of district hospital Väderö does with these patients. On admission they clinically evaluate උණ කැස්ස හතිය හෙම්බිරිසාව පොපි මහන්සිය පොපි කැක්කුම වගේ තියෙන කට්ටිය ඉන්නවා නම් පොඩි මහන්සිය මොකද හරි ඒගොල්ලන් අපි categorize කරනවා past medical history එකයි observations බලනවා, and it is a must to check saturation on admission at rest and after exertion. And all the patients, if the saturation is more than 92, almost everybody undergoes, unless they have contraindications, very well documented daily basis. They do this modified exertion or desaturation test, and this can be done. They have only 8 doctors and seeing 60 to 80 patients within 3 wards there. So they do this and record saturation values every 30 seconds for further 2 minutes. And daily, if you see the tickets, daily they do this morning and evening and use this value for further reference. And if the saturation at they escalate the treatment. So that is according to the guidelines. So there's no delay. We can treat them with triple therapy and triple measures. And if the saturation is more than 96 and if it drops below 95, patient has signs of exceptional symptoms, they start them on triple measures and we observe them closely for deterioration. And if they drop saturation below 94, we start steroids and all triple treatment. Closely monitor them twice daily with med test protocol, and if it drops below 94 at rest while exertion, again triple therapy, same thing. And if resting saturation is less than 92, as I said, they start treatment then and there. So if saturation doesn't drop from baseline, clinical features suggestive our doctors do med test protocol daily during stay. You can saturation එක drop වුණ නැතත් because අපි after 6th day saturation drop වෙච්ච කට්ටිය අපි because there's no correlation between the PCR date and the disease onset. So there's a lot of discrepancy, not like dengue day 1 where we know that exactly day 7 is dengue day 7 doesn't correlate with COVID day 7. So all patients before discharge undergo med test protocol, and this is a must criteria for all discharges. Now we have got quite a number of representers. Even now we have 1 or 2 patients who have represented after 2 weeks after discharge from certain centers with lethal desaturation levels, with chest pains, with various other complications. So it's a must to demonstrate and acceptable saturation levels before being discharged. And these are the values, so after all seeing 400 to 300 patients, they have managed to pick up 40 to 50 patients of early desaturation, and maybe 6 to 7 patients out of that 40 needed escalation of treatment, and they're doing a quite good job there. So again, final things, there are few more things that I need to tell you. There are a lot of collateral entities like COVID positive so they get myocardial infarctions, PV bleeding, and mind you, myocardial infarctions can get aggravated because of COVID direct viral damage and plus hypoxia, PV bleeding and severe anemia, stroke, surgical issues, a lot of other things are there. And sudden drop of SpO2 while in HDU ICU or in wards, again same thing is happening. So just to quickly run through 2-3 patients that we had. This is a 35-year-old female with 2 days 2 days of fever, 35 female, presented with a PV bleeding and was transferred for a blood transfusion with a hemoglobin of 6. And when we checked the saturation, we couldn't do the exertional desaturation test because of her anemia, but we just asked her to walk up to the pulse oximeter and check the pulse oximetry, and it was 96. And during this time, sorry, it was baseline saturation was 96, and after walking up to the pulse oximeter, pulse oximeter observe the saturation dropped to 91. So make anemia in the COVID pneumonia in the. So we got the X-ray doesn't look too bad, but see the HRCT of first 35 with HP of 6, bilateral severe pleural based, all lung fields are involved, and typical changes of COVID pneumonia. And we started with these measures even with the PV bleeding, So this is a very nominal dose of enoxaparin. And this is the blood picture, and patient survived and went home after. So not only anemic patients, they can have desaturation, anemia plus hypoxia can kill the patient. So we have to be very vigilant of. So not only giving a blood transfusion, needs steroids and other therapeutic measures as well. So the key is to diagnose them with desaturation test. So you can do the desaturation test in 2 ways. Either you ask them to stand and sit for 8 to 10 times and check the saturation, or else you ask the patient to come to the pulse oximeter. That's what they are doing usually. That they are willing pulse oximeter dala balangino. So එහෙම නැතුව දැන් සාමාන්‍යයෙන් ගොඩක් වෙලාවට ඔය සයින්ස් වලින් අපි 2010කට විතර ඉස්සෙල්ලා කතා කරනවා and දෙකේ ඉඳන් 10 වෙනකන් එන්න කියලා. So පළවෙනි එක්කෙනා maybe we are checking this desaturation correctly, but ඉතුරු 9 දෙනාම පළවෙනි එක්කෙනා check කරනකන් resting phase එකේ ඉන්නේ. හැබැයි ඒතකොට ඒගොල්ලන්ගේ බැලුවොත් we are checking the resting saturation of the rest of the people. So if you want to do that, you ask patients one by one to the pulse oximeter, and soon after coming, if you do it, still you can test these things. Again, this is a patient with STEMI, came with post PCR day 12. See, now almost patient would have discharged by day 10 if the COVID symptoms were not there. So day 12 STEMI with a troponin of 132 with for continuation of enoxaparin. So see, this is again one of the saturations which were recorded 95 does it look normal? So for this patient, this is not normal. So again, we were able to do a HRCT on her, and it was full-blown COVID pneumonia. So is it due to this instem is due to direct effect of viral damage, or is it due to thrombosis, or is the thrombosis viral damage plus hypoxia worsening the situation? So all multifactorial things play a role. So in this patient, only enoxaparin may not be helpful. So this patient needs steroids as well, and other triple therapy and measures to along with it. Right. So this is the chest X-ray of hers and HRCT reporting. And as I said again, tissue oxygen level depends on supply and demand. COVID pneumonia is considered a hypermetabolic state. Any degree of accession is not good during the acute desaturation phase. So to wrap up everything, finally, to recognize the difference between the resting saturation and post-accessional desaturation, it is very important. Saturation is not a static measurement. Ideally, we should measure ambulatory SpO2. In a normal person, it appears static because there is no imbalance between the supply and the utilization. But with COVID, it is different. There is a serious issue of oxygenation process at pulmonary capillary end, and there is a greater utilization and unloading at tissue levels as COVID pneumonia is considered a hypometabolic state. Simple measures and tools can make a big difference. So this is again first case which was diagnosed at district hospital Vathra, done by the DMO. He did the desaturation test, and it dropped to 94 after initial 30 seconds of lag period after doing the test. And we got a CT scan done, and patient had COVID pneumonia. We transferred the patient to, I think, somewhere at the hospital or somewhere. And the following day, patient had desaturated there, and the testing saturation was 92% with 6 liters of oxygen. So within 1 day, patient has deteriorated, but even at district whether at this time patient was asymptomatic, and we diagnosed 24 or 48 hours earlier. Yeah, and we confirmed with CT, but during that time we only had 4 cylinders at district hospital Vathra, so we had to transfer. But this is kind of, because these patients need not to be transferred in the first place. They can manage in those smaller places alone. Transferring is detrimental to at least yes, of course, if the oxygen is not there, if the facilities and if the expertise and the covering up is not there, yes, you have to do a safe transfer, no question about it. But do not just transfer for the sake of transferring. So patient desaturated on the way. So and we are coming to the final slides. Acknowledgements and limitation and requests. All patients who gave consent to record the videos for the good of the many, to use these videos and their data for educational and research purposes only. So I'm very grateful to all the patients who gave consent. And one patient gave the consent, recorded, but unfortunately the patient is no longer there. So in memory of some patients as well, and for those who have helped to bring this effort forward, a lot of people, a lot of consultants, junior doctors, nursing staff, minor staff, we helped a lot take these videos and a lot of things. They helped a lot to bring this forward, and all staff of DHH, District Hospital Vathra, Omagama, IDH, and Ministry of Health, and all the other smaller hospitals who helped us in bringing this topic forward. And I hope you gained some knowledge, take-home messages. Do not exert patients unnecessarily. Second thing, early diagnose it by doing a meticulous pulse oximetry, and advise them to rest, and when necessary you can do a safe transfer, and just don't want to transfer the patient just for the sake of transferring. And if you decide to transfer a patient, please make sure that you just not allow the patient to desaturate on the way. So these measures, triple treatment, triple measures, COVID speed, window period, all matters. And these are like some basic bedside measures that we can do. And one important thing, if we allow, whenever we allow bystanders to be there with the patients, of course, the test positive bystanders, the outcome is more. So the deterioration is less. So thank you again for this patient listening. I know it's a quite lengthy presentation, but I think it's worth listening and to learn few things and to take more messages. And thank you so much for giving me this opportunity. I'll hand it back to Dr. Dilantha.
Thank you, Dr. Mahendra, for that informative and comprehensive lecture. There was one question there that can you please explain the second component of triple measure, the wake prone thing? I think the proning position they are asking.
Right. So the prone positioning is that you name it awake cyclical prone positioning. Prone positioning is like අපි අර මම එක සිංහලෙම කිව්වොත් අර ඇඳේ ෆ්ලැට් ඇඳක කොට්ටේ නැතුව මුණින් අතට නිදාගන්නේ ඔළුව පැත්තකට හරවලා ඒ පොසිෂන් එක ප්‍රෝන් පොසිෂන් කියන්නේ. එතකොට ඒක ලෙඩාට දැන් අපි මේක ගොඩාක් වෙලාවට දැන් අපි HDOs වල ICUs වල අපිට අවශ්‍ය වෙනවා staff support prone positioning කරවන්න ventilated patients ලව. හැබැයි නිකන් wards වල ඉන්න patients ලට ඒගොල්ලෝ they can sleep on their face down. පපුව ඇඳ පැත්තට ගෑවෙන්න නිදා ගන්න පුළුවන්. අපි ඒගොල්ලන්ට කියනවා පැය දෙකෙන් දෙකට. දැන් අපි දන්නවා දැන් කරාපිටිය රෝහලේ වගේ මට එහෙ විශේෂඥ වෛද්‍යතුමා කිව්වා ඒගොල්ලෝ සමහරලාට ඕවර්හෙඩ් කරලා කියනවා කියලා ඉවරලා 10ට දැන් ඕගොල්ලෝ ප්‍රෝන් පැත්තට යන්න 12ට left lateral ඉන්න අර එකම තියෙන අර සීලින් එක දිහා බලාගෙන අයිඩල් අර උඩ බෙලිය අතර නිදා ගන්න පොසිෂන් එක අඩු කරන්න කියන එක. ඒකට පැය දෙකකට විනාඩි 10ක් 15ක් මුණින් අතර නිදාගෙන ඉන්නවා. ඊට පස්සේ right lateral position එකේ දකුණු ඇලයට නිදා ගන්නවා. ඊට පස්සේ වම් ඇලයට හැරෙන්න කියනවා. So අපිට ඔය වගේ wards වල අපිට ගොඩක් වෙලාවට overheads තියෙනවා. ඒතර patients ලට කියන්න පුළුවන් even desaturation නැති කට්ටියට. ඇඳේ ඔයගොල්ලෝ එක තැනකට ඔහොම වෙලා ඉන්න එපා. ඔයගොල්ලෝ පැය දෙකෙන් දෙකට මම අර කරාපිටියේ ડોක්ටර්ස් මට ડોක්ටර් ජයසේකර විශාන්ත ජයසේකර සර් කියපු ඒගොල්ලෝ එක පැය දෙකෙන් දෙකට කරන්න කරනවා කිව්වා. එතකොට ඒ වගේ එකක් අපිට කරන්න පුළුවන් ටිකක්. Prone positioning කියන්නේ just that patient has to එයාට patient එක පුළුවන් අනිත් පැත්තට හැරලා මුණින් අතට නිදා ගන්න. Yes, Dilantha. I think lot of questions in the chat. There are a lot of questions, Dilantha. Yeah, chat box එකේ ගොඩක් තියෙනවා. I think too many, 70 to 80. I don't know responses or questions are there. We can take a few more questions, if at all, Dilantha. Hello.
Sorry, there's another question. Is there any test for patients who can't do sit and stand test?
Yes. දැන් ඒ වගේ ලෙඩ තමයි දැන් අපිට ඇවිදින්න බැරි කෙනෙක් ඉන්නවා නම් දැන් ඒ වගේ දැන් ඇත්තටම අපි මේකේ contraindications තියෙනවානේ. patient chest pain නම් shortness of breath තියෙනවා නම් you should never try these tests. ඒගොල්ලෝ they should be ඒගොල්ලෝ ඇඳේ rest වෙලා ඉන්න ඕනේ. හැබැයි දැන් වෙන ප්‍රශ්නයකට හිත ගන්න ඉඳ ගන්න බැරි නම් අපි ඒගොල්ලන්ට තමයි කියන්නේ අපි ගොඩාක් වෙලාවට මේ පොඩි hospitals වල even at අපේ hospitals වලත් ලොකු hospitals වලත් වාට්ටුව තියෙනවා pulse oximeter තියෙනවා අපි observation station එක තියෙනවා patients ලට ඒගොල්ලෝ ඇවිදගෙන එන්න ඕනේ ඇඳේ ඉඳන් observation ඇවිදගෙන ඉන්න පුළුවන් කට්ටියට of course අනිත් කට්ටියත් ළඟට ගිහිල්ලා අපේ nurses ලා අපේ doctors ලා ඒගොල්ලෝ බලනවා ඒක හරි නමුත් ඒ කට්ටිය ඇවිදගෙන එනවා ඒකට අපි අර time කරනවා හරියටම ලෙඩාට pulse oximeter on කරගෙන ඉඳලා ලෙඩා ඇවිදගෙන ආපු හැටිය pulse oximeter දාලා ඉවර වෙලා just 1 to 2 minutes observe කරගෙන ඉන්නවා අර දාපු හැටිය සමහරට ඇවිදගෙන ආපු හැටිය ඒගොල්ලන්ගේ 98ක් 99ක් තියෙන්න පුළුවන් but ඒ වුණාට අර pulse oximeter දාලා විනාඩියක් විතර බලන් ඉඳිද්දි තප්පර 30කට විතර පස්සේ if they start dropping it will start dropping that ඒ exertion එක ඇති ඇඳ ගාවින් නම් pulse oximeter ආපු ටික ඇති මේගොල්ලන්ගේ saturation 98 තියෙන එකක් 94ට 92ට අඩු වෙන්න දැන් මට දැන් අපි දැන් ආවොත් එහෙම දැනට ඉන්නවා වැත රෝහලේ එක patient කෙනෙක් යාගේ saturation එක 80ට drop වුණා පොඩ්ඩක් එහෙට මෙහෙට ඇවිදලා check කරද්දි so ඒ වගේ ගොඩාක් ඒක ලොකු variation එකක් තියෙනවා. නමුත් අපි අර කරන්නේ ඒගොල්ලන්ව මේ early detect කරගන්න එක. හැබැයි දැන් dyspneic patients ලගේ ඉතින් අපි කොහොමද saturation එක කරන්නේ chest pain හරි මොනවා හරි ඉන්න ICU HDU ඉන්න patients ලට අපි කොහොමද ඒක saturation check කරන්නේ yeah
what can we do for these people who can't do this exercise?
Again same thing. Again exercise කරන්න එපා කියන්නේ මොකද ටෙස්ට් එකක් බලන්නද?
ඔව් ඒ කියන්නේ sit and stand කරන්න නැත්තම් මොකද කරන්න කියලා අහන්නේ.
නෑ ඒක තමයි මම කිව්වේ දැන් ඒගොල්ලන්ට දැන් ඒගොල්ලන්ගේ contra indications නැත්තම් dyspneic pain නැත්තම් chest pain නැත්තම් sit and stand බැරි නම් අපි ඒගොල්ලන්ට ඇවිදගෙන එන්න පුළුවන් නම් ඇවිදගෙන එන්න පුළුවන් නම් pulse oximeter එක ගාවට ඇඳ ගාව ඉඳන් අපි ඒ ඇවිදන් ආපු හැටියෙන් pulse oximeter එක දාලා බලනවා. ඊට පස්සේ විනාඩියක් ඔබ්සර්ව් කරනවා. එතකොට මේ මහන්සිය ඇති ඒගොල්ලන්ගේ desaturation වෙනවා නම් අඩු වෙන්න. ඒක අපි කියනවා ඒක අපි වර්ක් කරලා තියෙනවා ඒක very validated test එකක් තියෙනවා 40 steps walk test කියලා. හිතගෙන හිත ගන්න බැරි කට්ටියට අපි කියනවා පොඩ්ඩක් අතරට දැන් එහෙම නැත්නම් අපි ආයෙ කියනවා pulse oximeter ගාවට ආවට පස්සේ saturation එක බලනවා baseline saturation එක 98 තියෙනවා නම් අපි ඒගොල්ලන්ට කියනවා ඔයා ඇඳ ගාවට ගිහිල්ලා ආපහු වෙන්න. toilet එක ගාවට හින්සරේ ඇවිදන් ගිහිල්ලා ආපහු වෙන්න කියලා ආපහු හිටිය ආයෙ pulse oximeter දාලා බලනවා. That is the other method of doing this.
තව එකක් තියෙනවා how to wean off oxygen therapy.
Yes. පළවෙනිම එක තමයි ඕනම දැන් ICU මේ එකක් තියෙනවා. පළවෙනිට ඉන්සල්ට් එක හොඳ වෙන්න ඕනේ. ඇයි අපි ඔක්සිජන් දාන්න හේතුනේ කියන හේතුව ඉවත් වෙලා තියෙන්න ඕනේ. එතකොට ඒ කියන්නේ patient recovery limb එකේ ඉන්න ඕනේ. එතකොට දැන් patient අපි කියනවා escalation and de-escalation කියලා අපි treatments method දෙකට කියන්නේ. escalation කියන්නේ දැන් අපි from a smaller method සමහරලාට escalation සමහරලාට අපිට escalation කරන්න බෑ. දැන් patient කෙනෙක් dyspneic with saturation 80 આવොත් එහෙම සමහරලාට අපිට clinical judgment එක කරනවා NRBM එකම කෙසරේ පටන් ගන්න වෙනවා. එහෙම නැත්නම් gradually worsening වෙන කෙනෙක් නම් nasal prone එක දාලා face mask එක දාලා you can escalate. හැබැයි de-escalate කරද්දී එයාට පළවෙනි එක තමයි patient should be clinically comfortable, not dyspneic at rest. හිටපු oxygen delivery device එකේ සහ flow rate එකේ now say for example face mask එකක 10 liters ඉන්න patient කෙනෙක් measure oxygen ප්‍රමාණයත් එක්ක comfortable වෙන්න ඕනේ. respiratory rate හොඳ වෙලා dyspnea අඩු වෙලා saturation above 97 90 maintain වෙනවා නම් ඒක පැය 3-4ක් එහෙම ඉන්නකොට right then we know that so okay now this patient is stable on that. එතකොට අපි කරන්නේ ඒකෙන් අර තව ඔක්සිජන් ලීටර් දෙකක් විතර අඩු කරලා බලනවා observe it for now further 2 hours like see if the patient is maintaining. එහෙම de-escalate කරනවා. හැබැයි main thing is that දැන් face mask එකේ ඉන්නවා නම් ඔක්සිජන් ලීටර් 6ට ආවට පස්සේ ආයේ 4 කියලා ඒකෙන් අඩු කරන්න බෑ. දැන් ඒකයි මම ඉස්සෙල්ලා කිව්වේ දැන් අර oxygen flow rate එක වගේම device එකක් de-escalate කරන්න ඕනේ depending on the degree of de-escalation. Less than 6 liters then 6 liters වල face mask එකේ stable ඉන්න patient කෙනෙක්ව de-escalate කරන්න ඕන නම් face mask එක තියාගෙනම 4 liters කරලා බෑ. එතකොට patient get worse. මොකද ඒගොල්ලන්ගේ rebreathing effect එක වැඩි. patient exhale එයා ආපහු rebreathe කරනවා. ඒ හින්දා අපි කරන්නේ එතකොට ඒ වගේ වෙලාවට 6 liters වල හොඳට එයා ඉන්නවනම් device එකක් change කරනවා. එයාට nasal clones දාලා ඉවරලා again 4 liters විතර දාලා බලනවා. right. ඒකේ හොඳට ඉන්නවනම් ඒකේ 2 liters කරලා ඉවරලා we can take off oxygen. හැබැයි ඒ nasal clones එකේ දාලා ඉවරලා 2 liters 4 liters වල ඉන්න බැරි නම් again you have to come back to face mask and
okay. Then it is the same question. What are the cutoff levels and how to monitor and detect to wean off? The same answer, I suppose. Yeah, what would be the auscultation findings of COVID pneumonia? Is it possible to identify auscultation? Hello? Dr. Mahendra, are you still there? Dr. Mahendra, are you still there? I think your mic is off. Muted.
Sorry.
Yeah.
Sorry again මම කිව්වේ මේ එක මොකක් හරි වුණා. Yeah මම කිව්වේ දැන් de-escalate කරද්දී දැන් device එක වගේම මේ device එක වගේම we have to flow rate එක වගේම device එකක් de-escalate කරන්න ඕනේ. සමහර වෙලාවට face mask එකේ ඉන්නවට වඩා ලෙඩෙක් ඒකේ uncomfortable නම් සමහර වෙලාවට nasal prone එක ඊට වඩා more comfortable වෙන්න පුළුවන්. ඒකේ advantages තියෙනවා. That they can breathe, they can eat, they can drink, they can move around with the nasal prones and less chance of rebreathing effect the nasal prone එකේ. So ඉතින් ඒ හින්දා de-escalate කරනකොට හේතු ගොඩාක් තියෙනවා. නමුත් yeah.
Then there's one thing, what would be the auscultation findings of COVID pneumonia? Is it possible to identify by auscultation?
Yes. So if you so the main thing is that you have to auscultate clearly, and without now with this the current PPE kit, you know, wearing a stethoscope and getting it done, and so you have to combat a lot of things. But if you were able to, yes, you can hear crepitations, but may not hear the typical pneumonia changes like bronchial breathing and, you know, pleural rubs and everything. You may not be able to appreciate, but the crepitations are well heard, but may not be heard initially. But in full-blown COVID pneumonias, yes, you can hear crepitations. If you, but lot of interferences are there due to the various layers of PPE kits and wearings and all, and a lot of difficulty in getting the stethoscope in. But always you can hear crepitations. Yes.
Then there is another question on what basis enoxaparin duration should vary and what is the duration of treatment?
Yes, enoxaparin again, that depends on, you know, desaturation group and moderate to severe group according to the national guidelines, and usually 40 milligram daily subcut. And if the patient is having some, so there are a few other things that you need to adjust the enoxaparin dose depending on the EGFR level. Sometimes you might tend to give 20 or 30, or if the EGFR is further low, below 30, sometimes you can't give enoxaparin because enoxaparin is cleared through the renal pathway. So you need subcut heparin දෙන්න පුළුවන්. heparin subcut දෙන්න පුළුවන් 5000 unit BD. ඒක inoxaparin අර 40 දෙනවා වගේම අපිට ඒක දෙන්න පුළුවන්. ඊට අමතරව අපි inoxaparin dose එක then 40 days, usually up to 10 days තමයි අපි දෙන්නේ. But if the patient is desaturating further, sometimes some patients like still even after 10 12 2 weeks like patient ඒගොල්ලන්ගේ saturation එක still 80යි 90යි අතරේ තියෙන්නේ. So එතකොට ඒක එකක් COVID වලට සහ එකක් DVT prevention වලට මේ හැම දෙයකටම so longer period, sometimes 2 to 3 weeks දෙන අවස්ථා තියෙන්න පුළුවන් depending on the patient, but usually 10 to 12 days වලට පස්සේ you can take it off. පළවෙනි එක. දෙවෙනි එක තමයි if you have අපිට D-dimer එකක් කරගන්න පුළුවන් නම් according to the national guidelines, if it is more than 1500, or sometimes, or if the other risk factors are there, like more prone for pulmonary embolism and all. Now, say for example, surgical patient with a fracture neck of femur, sometimes you might need to give, enoxaparin, maybe a therapeutic dose. And if you have the luxury of doing a D-dimer levels, if it is less than 1005 usual guide type, you give daily dose, but if it is more than 5540 BD. දැන් අපි UK වගේ guideline එකක් ගත්තොත් සමහරලාට ඒගොල්ලෝ 60 BD වගේ එකක් therapeutic dose එකක් recommend කරනවා 1 to 1.5 milligram per kg dose එකක් වගේ. So a lot of variations are there, but I would like to stick to our national guideline 40 daily or 40 BD or less than 30 or if contraindications to give heparin 5000 BD.
There's another one. Is there a correlation between exertion desaturation and pulse rate?
Yes, of course. Yeah, exertion means that heart rate goes up. So I mean, usually heart rate in pneumonia is considered a septic state. And it's a hypermetabolic state. So usually the pulse rate is around 80 to 100, and pulse rate also can increase up due to exertion hinda වෙන්නත් පුළුවන්, fever hinda වෙන්නත් පුළුවන්, dehydration hinda වෙන්නත් පුළුවන්, sepsis hinda වෙන්නත් පුළුවන්, agitation hinda වෙන්නත් පුළුවන්, lot of other reasons. But desaturation එක කරද්දි pulse rate එක පොඩ්ඩක් වැඩි වෙන්න පුළුවන්, මොකද ඒක exertion එකක් නේ. Yeah, and hypoxia අඩු වුණොත් එහෙම the usual physiological mechanism is that hypoxia එක detect කරපුවාම tissue level එකේ hypoxia එකක් අපි physiologically detect වුණොත් එහෙම body thinks that the blood supply is low, so it will increase the cardiac output and rate to increase the tissue demand. Tissue එක signal වෙන්නේ මේ oxygen අඩුයි කියලා නෙවෙයි, මේක blood supply අඩු හින්දා oxygen අඩුයි කියලා වගේ signal එකකුත් යනවා. ඒ හින්දා එතකොට heart rate, depth, cardiac output වැඩි කරගන්න measures ටිකත් එහෙමත් වෙනවා. So usually these patients due to various reasons tachycardia. So there's a correlationship between this desaturation test and tachycardia. Yes, but not to septic level. Can ඔය 120 වගේ යන්නේ unless if it is going beyond 120, then you have to think something else, hypocapnia or some tachycardia, so arrhythmias, but usually around 100 due to various reasons. It's a commonly observed thing. Yes.
Then is there any relationship between CRP and extent of pneumonia? What is the use of CRP in assessment of severity of pneumonia?
Yeah, it's very good test to assess. Very good test, very good supportive evidence. But in most of our hospitals we cannot get a CRP done. So, but severity, sometimes the beauty of the CRP is that sometimes so some patients they have CRP of over 150, 180, nearly 200 values, and with the initial 10 days of treatment, mind you, their procalcitonin levels are low. Bacterial sepsis එකක් තියෙන්න ඕනේ, CRP can go up, and within 2 weeks sometimes their CRP level comes to less than 10 or even 0 කියලාත් වෙනවා අපිට. So it drastically responds to this initial treatment with COVID pneumonia. And CRP එකක් වැඩි නම්, yes, like LDH, like ferritin, like interleukin 6, like other markers, it's very well, and yes, this neutrophil set, leukocytosis and all those markers, it's a very good marker. But sometimes unfortunately some patients අපි හිතුවට වඩා සමහර වෙලාවට එක්කෙනෙක්ගේ දෙන්නෙක්ගේ එච්චර ලොකු CRP values ඉන්නේ, but it's not, depending on the CRP, your management doesn't change. That is the most important thing. Saturation is the main thing. Saturation එකයි patient clinical setup එක තමයි main thing. But all the CRP everything are supporting. Sometimes CRP එක වැඩි වෙලා තියෙනවා නම් ඒක අඩු වෙන්නේ නැත්නම් procalcitonin එකක් තියෙනවා නම් other bacterial sepsis. But mind you have to do the blood cultures, you have to do the urine UFRs and everything to these patients if you are suspecting something other than COVID sepsis.
Then there's a lot of questions.
No worries.
Yeah. When to start antibiotics? Then what is the exact dose of IV dexamethasone?
Yes, antibiotics again antibiotics depends on now if you see the WHO criteria, right? If the patient is meeting septic criteria like fever, tachycardia, and hypotension, and those things with even with COVID pneumonia, yes, you can start on IV antibiotics empirically. And if the patient is having fever and a lot of other signs are there, like cough and just and any lung signs. Yes, you can start. But the routine use of antibiotics, sometimes, desaturation group, sometimes we tend to give antibiotics, but it's an individual basis. Sometimes when the CRP is high, some people tend to give antibiotics. Even the procalcitonin levels are high, some people get to give antibiotics. The UFRO, even the white count cell count is high. But main thing is that, and giving antibiotic, you give antibiotic to prevent sepsis. You can get bacterial sepsis as well due to various other reasons. But it's maybe all right to start empirically if the patient is meeting any of those septic criteria, but you have to use judicious use of IV antibiotics. And coming back to dexamethasone, the only trial that we have done, in the world, credible trial is that recovery trial, which recommends 6 milligram IV for 10 days for desaturation group. Actually, they recommend it for the ICU and HDU setup type ventilated patients, but in our national guidelines, moderate to severe group, we recommend 6 milligram IV for 10 days. But the main thing is that, sometimes, after 10 days, in certain situations, you may have to continue steroids, maybe in the form of steroids, or maybe in the form of, maybe in the form of dexamethasone, or maybe in the form of prednisolone. So usual guide is in our hospital is that I told you we have the luxury of getting a HRCT. Sometimes, if the patient is this saturation is persisting for more than 2-3 weeks, we get a HRCT done. If HRCT organizing pneumonia pattern like COP, like cryptogenic type of pattern with crazy paving and all. Sometimes we higher dose of prednisolone 30 to 50 milligram daily dose continue maybe to 2 to 6 weeks or even longer.
Yeah. Then is there any full blood count pattern to catch the severity of COVID speed, platelets?
That is still even we are trying to establish the entity these days. COVID speed is desaturation and all. Most probably we might be able to write a paper on that, but we haven't looked into the other correlationships initially. But it is well known that white cell count and this neutrophil leukocytosis with lymphopenia type of things, platelet count, yes. In the වැඩිුණොත් ඉතින් බෑනේ ඉතින් මේ දවස්වල අඩුවුණොත් we first think of dengue with COVID other than දැන්ට අපි දැන්ට patients ලා තියෙනවා with platelet count 60 එතකොට අපි COVID වල platelet drop එකක් අපි observe කරලා නැහැ. So maybe more rational to think like dengue. Yeah.
One last question. Can aspirin and clopidogel be empirically used for asymptomatic PCR positive patient to prevent thrombosis?
The thing is that, I would like to stick to the national guidelines. Then national guidelines, we have a the therapeutic committee then empirical use of, there are a few other drugs like not only aspirin we do not use, but certainly I know that certain other countries, maybe Italy or some other countries, they may be giving aspirin empirically even for the young patients. So that all depends on the local guidelines, but I think ours is quite good enough. There's no need. Patients, if they are on aspirin or clopid, we are allowing to continue it. And if the patient is having risk factors for cardiovascular risk factors, sometimes we can start aspirin in the desaturation group, and in case-by-case basis on other patients, if hypertension, diabetes, and cardiac risk factors are there with COVID and any concern, yes, you may, but not empirically for everybody. So a lot of other national guidelines doesn't support that either. Yes, Dilantha.
what is the place of immunosuppressants like tocilizumab in management of COVID in Sri Lanka?
So I tried to keep away from the HDU and ICU type of management during this lecture because my main focus is to concentrate on small and ICC type of patients, because we have 95% of the patients in our in this group. So 95% of the patients are being managed by the smaller hospitals. Even these patients, and tocilizumab is needed in maybe less than 0.1% patients these days, and there are some positive things there. So all I can say is that there are two landmark trials which was published. One, I think, in April 22, in most recent one in New England Journal of Medicine. It supports the use of tocilizumab, but along with steroids and other supportive care. So, and it is very expensive. So even the patients who now, say for example, tocilizumab දුන්නා කියලා ඒක දීලා අනිත් ඒවා මුකුත් නොකර බලන් හිටියොත් nothing will happen. So it is not a wonder drug at all, but it has shown some improved benefits in certain people with ICU and patients at දැන් අපිත් එක දෙනවා වෙන කට්ටිය improve වෙනවා. But it's not a wonder drug at all, like others, ඒක දුන්නා කියලා but ඒක විතරක් so there's a mixed evidence, but more favorable evidence in the literature. අපේ නිජේම් එකේ එහෙමත් එහෙම ආටිකල් එකක් තිබුණා ඊට මාස දෙකකට කලින් නිජේම් එකේ it was against use of tocilizumab, and 2 months later, like in April 22nd, තව ආටිකල් එකක් තිබ්බා, it was recommended use of tocilizumab. And අපිත් ටිකක් දීලා තියෙනවා. I think අපේ hospital එකේ with mixed evidence, some people survived, some succumbed. So exactly with අපේ evidence එක multi center අපේ කීයක් දුන්නද කියලා ඒක අපි තාම rational මේ එකක් කරලා නැහැ ලංකාවේ, කීයක් දුන්නද කීයක් survive වුණාද කියලා. But a lot of confounding factors are there. tocilizumab දුන්නට වැඩක් නැහැ, ලෙඩ බහැලා toilet යනවා නම්. So that's sort of a, so the trials කරන හැම රටකම all the other confounding factors they indicate very carefully, and ඒවා ඔක්කොම silent කරලා තමයි tocilizumab effect එක හොයලා තියෙන්නේ. So in those setups, then දැන් අපේ ලංකාවේ tocilizumab හොඳ නෑ කියන්නේ evidence නැති, මොකද අපේ lot of other things needs to be improved. Even the care එකේ ඉඳන් drug එක විතරක්ම fail කියලා label කරන්න කලින්. But again, tocilizumab has shown some promising evidence in certain patients. Yeah.
Okay. Thank you, Dr. Mahendra, for that informative and very lengthy lecture. I mean, we have spent almost 2 hours. It shows the enthusiasm of participants as to stay in that kind of hours, 2 hours. So I would like to thank Dr. Mahendra Ekanayake for delivering this wonderful lecture. At the same time, I would like to thank DDG Medical Services 1 and 2 for their giving the guidance, and also to the media unit of Ministry of Health, spearheaded by Mr. Viraj Abesingha, for organizing the recording of this lecture, and all the participants who have come here. As most of them have asked, we will be distributing the recorded version and the, if possible, PowerPoint with the consent of Dr. Mahendra Ekanayake. If he agrees, of course, we can send you to the WhatsApp the recording, and the PowerPoint presentation PDF version, if possible. So thank you very much again for joining with us, and we hope to have these kind of lectures through Zoom, then distribute them through our WhatsApp group to the intermediate care centers, medical officers and nursing officers. And thank you everyone. Thank you very much.
Thank you, Dilantha, for giving me this opportunity. Thank you everybody for patience listening. Thank you.